get comfy. Turn on the screens here.
Tried it on this morning sneakily, and I upset my hand, so I almost couldn't get it out. Me and Victor, I can't wait for Chris to try it.
It's alright, when I found out where I'm finding a diamond.
I'm just saying that last
Because he has a diamond at the house really.
So I
You can tell that he just wants to get it over with because he's
So I thought I would start with a clarification.
yeah.
I mean, one of the points of confusion, and that Karina actually pointed out to me that I should be a little bit more clear about, was with this quiz on functional groups. As you recall, I didn't really input the questions all that well, as not very professionally. And as this quiz, the first part, you're shown a number of structures, excuse me. And then I asked where the groups were. And the particular confusion was like, we had some sulfonamides, and later in number 4 I asked for a ketone. And a ketone is not actually part of a amide, or I guess sulfonamide was clear, so that's, sorry for confusion. Again, I'm confusing you more here. But really the real issue was with ketone and how I gave credit, or I enabled credit, or at least in a weird way, for people who chose the amides. Because I was like, well, there's a ketone in an amide. Is that actually true?
No, it's an amide.
No. I just wanted to be clear here and not mislead people. These are amides. This is a carbonyl. A ketone, excuse me. And a ketone, in fact, has R groups attached to it. They're carbons. Okay? What my terminology issue was with those amides contain a carbonyl, not a ketone. They contain a carbonyl element to them. But a ketone itself is actually just connected to 2 carbons on either side. It's a ketone. Okay? Just wanted to clear that up. That was kind of an egregious error. I shouldn't be misleading you all like that. So, I believe I posted this key on the date, right? So that's on the website. So this key, this quiz with the key is there. So I just want to be clear about that in the future. Since it is very likely that I'll be asking about functional groups on your exam, so I want to make sure we're all on the same page. Any questions? Yeah.
So if we did only put the ketone and then mark it wrong because we didn't select all of the appropriate answers.
Is that what happened?
Yeah.
I thought it was actually graying out. Yeah.
No.
So it still says that we got it wrong.
Yeah. Yeah, and that's true. But for that quiz, this quiz was just, you got credit if you took the quiz. So everybody should have received 100 if they actually took the quiz. Is that the case?
Mm-hmm.
Yeah.
Yes.
No.
No.
POQ5.
POQ5.
Yeah.
You don't have you have an actual grade true and do it the same way?
Let me look now.
How many people have a grade and not a 100 for that? Can I just see some hands? That's
Looking.
weird. Are you sure we're talking about TBL5?
This is
No.
This is
No.
TBL.
Let's be clear. Okay, PLQ5 is HTN Part 2 quiz that Ron Hills administered to you. That's PLQ5. TBL5 was a quiz But it was just to take attendance, and you
Yeah,
should have
mostly.
received 100 if you took it.
Yep.
And there was confusion with how I administered it, but it didn't really matter. All I needed to see was that people that came to class. So do you see 100 there for your, okay. Okay. So yeah, there's a little confusion. I know I'm kind of mixing things up a little, but I just wanted to keep the order of our team-based learning and our PRQs and our grades kind of in line. So that's why I did that. And in the, yeah, one.
PLQ5, what was that?
PLQ5 was HTN Part 2 slides, a quiz over that. Dr. Hills. Administered on the
Last Tuesday.
last Tuesday, 22nd.
No, because today's only the
Wait,
24th.
wait,
Today's,
17th.
yeah.
More confusion. Okay, we get that. All right, so does this? Let's go to our heart failure, MI and thrombosis slides and start at the beginning. So our learning objectives. The first two were about the glycosidic and non-glycosidic positive inotropes. So those were these two that we covered today in that quiz. We're going to move ahead. We'll cover those, and then we'll go into the section on thrombosis, where we talk about heparins and factor XA inhibitors. We'll look at direct thrombin inhibitors, warfarin, and then we'll talk briefly at the end about aspirin, the ADP inhibitor, and the GP2B3A inhibitors, antiplatelets. First, heart failure. What is the... So Dr. Selvage, is he dwelling on ADH, antidiuretic hormone? Did that come up yesterday yet?
Last week.
Or any of these concepts? So did he talk about positive inotropes yet? He's kind of, because he's kind of, some therapeutics can be used for heart failure and for myocardial infarction, and so he might be grouping them differently along the way. I do think, like I said, I think we'll get to some antiarrhythmics, but you know, what we'll see in here is, you know, this is just the way I'm categorizing them, and they could be, and they are in other therapeutic areas. That's where it's really important. The cardiovascular section is so huge, such a large part of therapeutics, that it'll probably be organized slightly differently. Anyway. So I'm going to just talk briefly about antidiuretic hormone and the vasopressin receptor antagonists. Then we'll talk about glycosidic and non-glycosidic positive inotropes. So vasopressin receptor antagonists are diuretics for heart failure. The naturally occurring antidiuretic hormone is called arginine vasopressin, or AVP. It's an octapeptide. It has 8 amino acids and is similar to structure to oxytocin. Does anybody know about oxytocin? Does anybody recall what that does to a woman in particular?
It brings labor.
Induces labor, right. There was a project that I worked on at Merck that had a, they were working on peptides that were very similar to oxytocin, and it was a male-only project because the people in the laboratory might potentially come into contact with oxytocin-like materials. So if a woman was pregnant, or maybe didn't even know she was pregnant, it would be considerably risky for her. So this is one of those interesting laboratory cases, and they were really, and with peptides too, there's other safety protocols to kind of keep in mind. So these diuretics have an off-label use in the treatment of heart failure. This is the major antidiuretic hormone in humans, AVP. As you can see, it's a cyclic peptide. Cyclic, oops, let me just start that writing again. Cyclic peptide. And it has a disulfide linker. So we have 2 cysteine amino acids that have been condensed to form a disulfide bond and make a cyclic peptide structure. All of the other amino acids should be recognizable to you. It's taking my Sorry, technical difficulties here. The vasopressin receptor antagonists include convivaptan and tolvaptan. Conivaptan, excuse me. They have two types of selectivities. The ones that are selective for the V2 receptor, or the V2 subtype of the vasopressin receptor, that would be tolvaptan. So that's how those are differentiated. There's a lot of structural similarity. In fact, you can actually trace a ring around this molecule, and that's conserved between the two of them. That substructure. You can see in conivaptan and tolvaptan really are quite similar in just that core. Vasopressin unselective antagonists include the tetracycline antibiotics too. So that's a side effect of the tetracyclines. They're not selective, and particularly dimeclocycline, that one has vasopressin receptor antagonism as well. Oh my goodness. So this basically, I'm just describing here what heart failure is, or what congestive heart failure. The body becomes congested with fluids because you have this basically development of edema in the extremities and the lung. Both positive and negative inotropes are used for management of this. All of the drugs that we're talking about are the positive inotropes. So they actually increase contractility and support cardiac function. They're not actually allowing the heart to necessarily rest. Negative inotropes reduce contractility and reduce the workload in the heart. So we're talking about things that actually are like enhancing the heart's strength. But how they're used and how you decide clinically is certainly something you will learn later in therapeutics. So, the cardiac glycosides. So this is a great historical context for some drugs. The medicinally used cardiac glycosides are derived from plants. And usually in natural products, there's some kind of organism or type of living thing that something is obtained from. These are just a digitalis plant, which is a fairly innocuous-looking leafy plant. Many of the cardiac glycosides, in fact, most of them are extremely toxic. They're very effective poisons. They have a narrow therapeutic index, almost all of them. So once you get to there's an effective dose for very few of them that are used clinically, but most of them are just too dangerous to use in a clinical sense and have only been used in a devious way to poison people or in some kind of dramatic fashion like that. Wabain, or wabaining, or that this word right here, from its original language means arrow poison. That's a Strepanthus glycoside. Does anybody know what Strepanthus is? I didn't look up what organism that was, but I don't know. It's not from the same plant, but it was derived and used as arrow poison in the native tribes that had access to this plant. So it was isolated, but it's not used therapeutically. It was previously administered only intravenously because it was not orally absorbed very well. So currently, digoxin in green here is the only cardiac glycoside that's commercially available. And then I talk in this paragraph here about the digitalizing dose. So this is definitely a loading dose concept is something that you should be familiar with when you're talking about cardiac glycosides. You want to very rapidly reach the appropriate plasma concentrations and then apply a maintenance dose later on. So a digitalizing dose is the same as a loading dose in this case. The digitalis-derived cardiac glycosides It's called a digitalizing dose because they were one of the first drugs to be widely used that had a real defined narrow therapeutic window. So it was really necessary to specifically state how the drug was initially dosed. So toxicity. Essentially what I was looking for here is that toxicity can cause hypokalemia. There is increased intracellular levels of calcium, but potassium is decreased as well because of that sodium-potassium ATPase pump, which actually pumps both ions at the same time. So if the actual antidote to toxicities for cardiac glycosides is the administration of potassium salts, which activates that pump. So you have decreased intracellular sodium and also decreased intracellular calcium as well. So it's really the calcium. So I'm kind of all over the place here, but the cardiac arrhythmia itself is the calcium. We were just talking about how calcium has all these effects in the cell, and we were talking about calcium channel inhibitors too. But just that imbalance with calcium is really what's causing what can cause arrhythmias. And he's marking this up. Okay, so the positive inotropes that are glycosidic have two different parts. They have an aglycone part and a sugar part. The aglycone is a steroid, and it's a particular steroid with a set of cis-fused rings. So we can see the aglycone here is a flat view, and here is a side view. And because of the cis fusion here and here, we have a curved shape here. So like there is a bowl shape. If you were to look at this steroid nucleus in 3 dimensions, so it gives it that kind of U shape or bowl shape that I'm trying to say with U shape. And that's due to the cis fusions. You can see the cis fusions even more distinctly here up top. If I'll just like accent those, you can see that the substituents on each side of those, or the fusions of the 2 rings, are in a cis fashion. Also on these aglycone portions are lactones. So those are attached at the R' position. So this is R'. And these are lactones. So the steroids always have a lactone ring attached to the end of them. And I think I talk about those here. So the lactone ring, there are 2 types, the Cardenolide and the bufadienolide. All of the Cardenolides come from a plant origin, and all the bufadienolides come from an animal. So you know that our clinically useful ones that I've said both come from digitalis plants, or rather just digoxin itself. We can be assured that digoxin is going to have this cardenolide type of lactone. So this is a 5-membered ring. It's alpha-beta unsaturated. And that would be this double bond right here. And the alpha and beta position has been unsaturated. Bufadienolide have a 6-membered ring, lactone, and they have 2 conjugated double bonds. That can also be referred to in shorthand as an alpha pyrone. Okay, so that's the aglycone portion. It's always a steroid nucleus, cis-fused, and whether it's plant or animal origin is shown by the lactone ring that's attached to the R prime position. So the two major cardenolide aglycone portions that give rise to digoxin and digitoxin are called digoxagenin and digitoxagenin. So once we add the appropriate sugars, this will give us digoxin. And this digitoxin. Okay. Now I'm wondering if it's keeping my marks up here, so I'm going to close this for a second to try to save and reopen it. I'm just concerned it's not actually saving my marked up material for you. Let's try this again. It's not appear to be, but okay. Okay, so now attached to that aglycone portion are a series of sugars. The hydroxyl group at C3 of the aglycone. Let me just step back here. So this is carbon 3 or C3. There's a hydroxyl group here. That's the hydroxyl group. It's going to be attached to a series of sugars depending on what type of sugar portion we have and what the ultimate glycoside is. So attached to C3 are either a monosaccharide or a polysaccharide. In our case, we usually see a monosaccharide or a trisaccharide with 1,4-glycosidic linkages, so they're attached along the same in the same areas as you go along the chain. The number of and identity of the sugars do vary. If there's an O-acetyl group on a sugar, it greatly affects the lipophilic character. So we'll see that in a second, but if one of these hydroxyls, there's a lot of free hydroxyls. You have a steroid with a lactone ring attached to a whole bunch of sugars, and they're actually, because of all the free hydroxyl groups in water solubility, just adding an acetyl to one of those can actually radically increase the lipophilicity and change the characteristics of the drug. So, depending on what the aglycone part and what the sugar part are, defines what our glycoside is. So I put as two examples in red, Lanata-Derived A and Lanata-Derived C. Okay. Both of these are actually derived from digitalis lanata plants. All right. And you can see that the top Lanata-Derived A has the aglycone of digitoxagenin that we just noted, the portion, the aglycone part without the sugars. And Lanata-Derived C has digoxagenin. Okay. In order for them to be defined as Lanata-Derived A and B, the sugar part is actually written out here. So there are 4 sugars. So we have a glucose, a digitoxose, and a digitoxose. There's also a 3-acetyl, and that is totally spelled wrong. How about that? So this is acetyl. I just got that misspelled. So there are 4 sugars, one of them contains an acetyl group. And containing those sugars and those aglycone portions that gives it its name. You can see over here that there's other examples below. Here we have purpurea glycoside A. Just look at this. That has a digitoxygenin aglycone portion, and the sugar part is the same as the sugar part on the top 3, except it does not have an acetyl. Just pointing this out. Purpurea glycoside B does not have a sugar on it. And then going down, you can see we actually have different aglycones and different sugar parts. So there's a whole bunch of combinations here. These are natural products, and there's been a ton of them identified. So looking at Lanata-Derived A, it has the aglycone digitoxygenin. Digitoxygenin. Identifiable as a 5-membered lactone. And it's attached to 4 sugars, one of which contains an acetyl. So here they are. These sugars here, so we have a glucose, and then the rest of the 3 are digitoxose. And then digitoxose, digitoxose. And this one has an acetyl group. So that aglycone portion, that sugar portion, in that order, Lanata-Derived A. If you hydrolyze this, and it says if you, as I mentioned here, if you hydrolyze the glucose sugar on the end and the acetyl group, then you'll get, respectively, digitoxin and digoxin. So in this case, we have a digitoxygenin. If we hydrolyze both of these parts right here, so if we actually subtly chemically react this under the right conditions and cause it to degrade and lose that end glucose and that acetyl group, then what we are left with is digitoxin. Okay? So that's the result. So no acetyl from Lanata-Derived A, and no glucose from Lanata-Derived A. The same degradation with the Lanata-Derived C. We hydrolyze acetyl and glucose, and then we get digoxin. So there's the difference between digitoxygenin and digoxygenin. The 2 aglycone parts only differ by that hydroxyl group. But I just wanted to show you, so this is actually, Lanata-Derived A and B are the ones that are actually derived from the plant, like actually extracted, and there's a little bit of chemical processing that occurs in order to get digoxin. Probably most of the cardiac or the glycosides derived from nature have been modified in some way, so you had like this major chemical component, and they probably degraded it or added things to it and tested it as they went. And this was just a natural course of events. They had Lanata-Derived A and C. They did a degradation to remove the acetyl and the N-glucose. They got digitoxin, digoxin. Really, they found that digoxin had the best clinical clinical effect, the safest clinical effect. Does anybody ever use these, or have actually been in a hospital where they've been used?
You can. It's
Yeah?
a tablet. You
Oh,
can,
it's a tablet?
Yeah, you can buy it in the pharmacy.
Oh, okay. It's not a hospital thing as much as just a prescribed drug.
Mhm.
So do patients already have a maintenance dose? Do they do
Mhm.
that even? So they get a maintenance dose and then, or sorry, they had a loading dose and then they get a maintenance dose via prescription. Is that what I'm guessing? Okay. And it's only digoxin. Is there others?
No, just digoxin, I think.
Digitoxin was used and was looked at. It's just not. It has a even narrower therapeutic window. Okay, so it's not as safe. It is useful, but I think you need a lot more patient oversight. Maybe it would only be in that past it was only used in an inpatient situation. But there's a larger margin of safety for digoxin, so that accounts for the oral dosing and people taking it home. And is it a small amount? Does anybody know the amounts that are dosed?
0.125 to 0.25.
So small pills, little amounts.
Yep.
Okay. Which would make sense. They're quite potent. Okay. Is there any questions on those before we move on? Right. Okay. So I just had a couple of slides on the non-glycosidic positive inotropes. You see a beta agonist in there, but the first thing that of note will be the PDE3 inhibitors. Okay, so those actually, here's my pen, inhibit the hydrolysis of cyclic AMP, phosphodiesterase 3 inhibitors. Because they prevent degradation, they increase intracellular, and I can just barely get over here to highlight it. Increase intracellular cyclic AMP, so that promotes cardiac contraction. Milrinone is the one I was asking you about. It has fewer side effects, and that's because it has a greater selectivity for the receptor. So it's just a later design drug that had a little bit better selectivity. Inamrinone was initially used therapeutically, but not so much anymore. And dobutamine, you guys should be familiar with beta-adrenergic agonists. It has the it's a dopamine analog. It has that catechol ring on it on the end, and it basically has beneficial effects. So it actually has effects of allowing the heart, helping with heart failure. The same sort of rules apply for metabolism as we talked about before. Catechol O-methyltransferase, it is susceptible to metabolism. There have been no modifications made to this ring, like we talked about, to actually make that a meta-substitution pattern or a salicyl alcohol type of ring modification. It still has the catechol, so it's still susceptible to COMT metabolism. That's pretty much it. Okay, talk about MI and thrombosis. Moving on. I don't know if I actually covered all of these drugs. I don't think I actually went through and took out things that I didn't, but I did put in green and checked for the drugs that you would see most commonly, the top 200 drugs. In anticoagulants, we're going to talk all about dealing with thrombin and the whole pathway for formation of a clot. There's a whole set of really colorful slides that you will see in your cardiovascular therapeutic section that shows the cascade, and Dr. Selvage will certainly cover this cascade of effects. So I'm going to mention mechanism of action, and because these drugs specifically act on a different part of that cascade and what those blood coagulation factors are involved at a particular step. So so we'll get into that a little bit, but it's really just like where it's working in that cascade and how that's helping with coagulation. And then we'll talk about antiplatelets and thrombolytics. Thrombolytics are really just a cursory look because those are all enzymes. And I just wanted to familiarize yourself with what is actually out there. So, heparin acts at multiple sites in the coagulation cascade. Heparin's in our blood. It's in certain tissues in our blood. It is has a distinct pentasaccharide sequence in its molecule. It's much bigger than a pentasaccharide, but it binds to antithrombin 3 also. So it potentiates the inhibition of thrombin and factor XA. So this is the key point. Potentiates the antithrombin-mediated inhibition of thrombin and factor XA. As I mentioned, natural sulfate, heparin sulfate lines the vascular epithelium. It prevents clots from forming in your blood vessels. So it is part of your whole homeostasis that you have some heparin around to prevent your blood from just clotting if it comes upon any sort of reason to do so. There are different styles of heparins. Natural heparin sulfate, which has, and you can see the differences here where, in terms of molecular weight. I think that's the way that I actually look at it. And looking at it in terms of its specificity for factor XA. So the development of these drugs as it's gone has become more selective towards factor XA because more selectivity, you have a reduced incidence of side effects. You can see as we go down, I don't know really to comment on dosing, but heparin itself is known as UFH or unfractionated heparin. And then these three other peptide products here, including Lovenox, are called the low molecular weight heparins. They're smaller. Okay, so the highest molecular weight is heparin itself, which we'll look at a little bit more closely. Low molecular weight heparins are where we've taken natural heparin and we've removed a lot of the other the glycosides that actually are not useful in binding to factor XA. And then fondaparinux is actually a small molecule. Okay, so these are heparins, or is this an engineered peptide? Excuse me. This is an engineered peptide. So it's not a small molecule. Sorry, I can't define it as such. So fondaparinux is just the distinct pentasaccharide sequence that binds to factor XA. Or Rixtra. I don't know if there's other brand names for that yet. So looking at heparin. So it has a molecular weight range of 5 to 30 kilodaltons. Okay, so it's quite large. There are hundreds of sulfated sugars, all connected to each other. They're all negatively charged. And they're all isolated from either cow lung or pig intestinal mucosa. So as mentioned before, these are present in certain tissues of your body. So they are actually harvested from production animals in the food industry. That's part of the processing of them. As certain parts of the animals are used for medical products, or for drug products or starting materials. So there are many polymer chains. There's a very long polymer chain of sugars, and they're composed of alternating sugar units, one of which is the N-acetyl D-glucosamine, and then either and some kind of uronic acid, so D-glucouronic or adiuronic acids. You can see they're all linked together. Either sulfates can be either at the 3 or the 2 position. And sometimes these are an N-sulfate as well. So here's O-sulfate, and here we have N-sulfate. So I'm not necessarily going to quiz you about like what the order of these sugars are, but you should keep in mind we've seen sugars and polysaccharides before. They're all linked together. They're usually those 1,4 glycosidic linkages, so we have alpha 1,4 bonds here, so they're all connected together. But typically with a polysaccharide, all of those hydroxyl groups are free or kind of minimally substituted with something else. In this case, it's kind of hard to see with the font, and I apologize for that. This comes out of your textbook, but a lot of those hydroxyls have sulfates on them. So all the way across at physiologic pH, this whole molecule is negatively charged. Right? You'll see there are some carboxylates indicated as well, but mostly it's sulfated. And either one, at physiologic pH, either sulfonic acid or carboxylic acid is going to be deprotonated. It's going to exist as an anion. Okay? So that's heparin, 5 to 30 kilodaltons molecular weight. So unfractionated heparin binds to antithrombin 3. Again, I highly encourage you in your pharmacology slides to look through what Dr. Selvage said and that cascade of reactions that's causing the clot to occur. Because these are different factors along the way that are affecting the coagulation. This one, it's binding to antithrombin 3, so it accelerates thrombin formation. It is a large size, so a little bit of the PK characteristics. So we've already determined that this is a very large molecule and it's anionic. So almost certainly you put it into your body. If you were to take this orally, it's just like eating a polysaccharide, like eating a loaf of bread or some complex carbohydrate. Your body's going to identify it as such and degrade it really quickly. So there's no PO bioavailability. It has very high protein binding in your bloodstream. It has a relatively short half-life, and it is degraded enzymatically. So it's reversible in emergency, and it's reversible in the simplest kind of chemical manner possible. You have this highly anionic molecule. If you administer protamine sulfate, which is a very positively charged cationic peptide, you form a very stable ion pair with the heparins. So protamine sulfate is itself also a peptide. It can be administered as a rescue agent, and all it is forming a salt with the heparins, the free unfractionated heparin that's floating around in your bloodstream. Okay? So that could prevent an adverse event. Adverse events in almost all of these drugs that we're talking about, anticoagulants, are bleeding. Right? If you administer too much of an anticoagulant, then your blood is not going to clot as well as it should. And if you have any sort of, you can bleed internally, there can be bleeding events that happen in an uncontrolled fashion. To get them back into control, at least with unfractionated heparin, you can use protamine sulfate. Low molecular weight heparin also combines with antithrombin 3 and potentiates its activity, but it also has some activity against factor XA and thrombin as well. It has a more predictable PK. When it's given subcutaneously, it does have a very good bioavailability and less protein binding. So reversal is also possible in this case. We have a smaller molecule. We've reduced the molecular weight considerably for this low molecular weight heparin. So it has shorter chains on it, and it does not it turns out it just doesn't actually neutralize or form ion pairs as efficiently with protamine sulfate. So heparin, unfractionated heparin, less predictable PK, but very easily reversible. And low molecular weight heparins, more predictable PK, less reversible. So there's more predictable anticoagulation here, and there's an fixed weight based dosing, which I'm sure you will actually go into in therapeutics. And fondaparinux, although I misquoted earlier, is just a pentasaccharide. It's synthetically created in the lab. They attach 5 amino acids together. It reversibly binds to antithrombin 3 and factor XA. And then the small molecule inhibitors that I was trying to mention were rivaroxaban and apixaban. These are available for PO dosing. This is still sub-Q. It's still a peptide. It still would still degrade if you took it orally. And I don't know. I have apixaban in phase 3 clinical trials. Is that still true? Does anybody know? That's actually last year's information. So phase 3 is pretty close to being approved. Is apixaban actually a drug product that's FDA approved? No? No dice? Is there anybody's list anywhere? Phase 3 means it's getting close. So here's finally fondaparinux at the bottom. This is our 5. This is a pentasaccharide. Alright. And then here's rivaroxaban and apixaban.
It's available.
It is available. Okay. So apixaban has been approved. I put the structure of linazolid below that. Somebody know what linazolid is? Somebody seen that before? What kind of drug is that?
Antibiotic?
You guys had infectious disease,
Yeah,
right?
it's an antibiotic.
No?
No, but we start therapeutics today with infectious disease.
Today?
Yeah.
Oh. I thought you had it already.
No.
Yeah, that's I believe it's an antifungal. I want to say antifungal. Am I right? Oh, it's a TB medication. Is that right? What is it? Somebody look it up. Bacterial infection. Okay, so it's an antibacterial. But it has usefulness in TB. Well, TB is a parasite, right?
Still,
A what?
the mycobacteria.
A mycobacteria. It's a mycobacteria.
Yeah.
Okay. So linazolid maybe is useful for TB. Is that
Where's
useful?
the
Okay.
It's fine.
Not a parasite. Mycobacteria. Okay. Okay, I gotta get your facts straight. Is Dr. Allen starting today?
Mhm.
Good. He does an awesome job. So I just wanted to put out. I just happen to notice structurally they're similar. I don't know why I cross paths with those two medications, but I just noticed that rivaroxaban is really highly similar to linazolid, and linazolid's actually been around a lot longer, so it's interesting that it came out of that. Multi-drug resistant TB. Okay. But different mechanisms of action. So that's an interesting case where just a very small change can have a marked effect on the specificity of the drug. Okay, cool. Well, infectious disease is really cool. It's a cool topic. So, direct thrombin inhibitors. So these were developed from Hirutin. Does anybody know about leaching and leeches?
Mm-hmm.
Hirutin medicinalis. Has anybody ever seen it utilized? I thought it was used in surgical applications. So leeches actually, when they latch onto you, have anticoagulants that they release so that a clot doesn't form in the little incision they made to kind of suck blood out of you. So they have this natural anticoagulant factor that they actually absorb into your skin and the surrounding tissues. And how these leeches are applied medicinally are usually in microsurgical reconstructions. A great example I saw was of somebody who had their hand smashed horribly and had it all reconstructed in the bones. And one of the problems with that is not the microsurgery itself, it's the healing process. We've designed really effective microsurgical techniques so you can actually reconstruct all the tiniest tissues in your body. But once that's all done, you have to maintain blood flow to those little teeny vessels that you've reconstructed. And in fact, a lot of those microsurgeries were failing because of there wasn't a great way to get anticoagulants in those little vessels. If you took an internal dose, it just simply wasn't getting there. So they've started using leeches, which are just a plain old leech raised in some, they're probably raised in a fancy environment and it might be sterile and they charge probably $500 per leech. But it's basically a regimen of therapy. Like they're the reconstructed area. They'll let the leeches latch on. They actually eat more of the nasty stuff than the good stuff, in terms of what they're digesting. And they also are injecting these anticoagulants, Heparin, into the blood around those tissues. So the blood flow is actually maintained. And there's a remarkable difference in the outcomes. So I think this is really cool. It's cool because it's ironic because in the in the Middle Ages, leeching was kind of a thing, right? It was like what doctors did, and it was basically in the realm of quackery for hundreds of years. And then, hey, guess what? It actually has some benefits, some really significant benefits. So it's like this really simple approach. So direct thrombin inhibitors were actually isolated initially from Heparin, or from that anticoagulation factor present in these leeches. So these bind, again, this is the specificity. When you're looking at the coagulation cascade, and I'll just say selvage. This is actually binding to the catalytic site or the fibrin binding site of thrombin itself. And the site of binding actually is either to the active site or catalytic site of thrombin, and there are also two exosites. These are also given graphically in your coagulation cascade. All of these peptides here are bivalent, meaning they are affecting the catalytic site plus exosite 1. Whereas the small molecule inhibitors, argatroban and dabigatran, are actually just affecting the catalytic site only. So they're specific to just one site. They don't have that extra binding interaction that's occurring. Which kind of makes sense if you think about it. They're small molecules. They're not as big. The other four there are peptides. They have a larger area they can spread out and interact with thrombin. And I do want to note also that all of these are IV or sub-Q, except now we've got, with a small molecule inhibitor, we have a PO dosable drug with Pradaxa. So just some brief chemical information about the small molecule inhibitors, argatroban and dabigatran. Dabigatran is moisture sensitive. We have this portion of the molecule, and we have an ester over here. Probably choose the colors. I don't know how that happens. And here we have well, first of all, we have an imine. But both that imine and that ester at the very least are probably a little bit more moisture sensitive. And then I talk about the specificity of the two diastereomers of argatroban. It's dosed as a mixture because it's probably a lot cheaper to make that as a mixture of diastereomers. And the S isomer is about twice as potent as the R isomer. Okay, any questions? No? Still awake? Good. All right, let's talk about vitamin K antagonists. I think Dan Selvich has this exact slide with the rat poison on it. It was developed as rat poison at the University of Wisconsin in the 1940s. It inhibits vitamin K reductase, and it's the most widely used one. Basically, there is a, this is kind of hard to see, I'm sorry about that, it's dark. Color slides. I have to make it like dark in here now. You're alternating here between a reduced vitamin K and an oxidized vitamin K molecule. The reduced form is necessary for those clotting factors to be activated. And you need vitamin K reductase to form the reduced vitamin K, so that vitamin K reductase enzyme. And if warfarin actually blocks the formation of a reduced vitamin K derivative, then you do not have further activation of clotting factors. In the case of rat poison, they're overdosing on this, and they're bleeding out internally. That's basically what it is, you know. So we would not like to see that. All of the side effect slides that you're going to see with all of this section in cardiovascular are all going to say the main adverse event is bleeding. It's very obvious. If you overdose, if you have some kind of adverse event, you have to have some kind of contingency plan because there could be that kind of adverse event. You're dealing with anticoagulants. We don't have to talk about that. Factor S, all that stuff. So it was actually developed because cattle eating sweet clover hay would die from bleeding events. It turns out that they find that they isolated a drug product from this spoiled sweet clover hay, and isolated what was determined to be dicuberol. So the very first chemical compound was this. It was actually used starting in 1954 as an active anticoagulant drug. All of these are water-insoluble lactones. So these contain a phenyl ring. There's not many like, well, let's just say, not water-soluble. There's no free hydroxyl groups. There's no free amines. There's only hydrogen bond acceptors there, no donors. So if you look at coumarin itself, it doesn't have anything much. The dicuberol does have some hydroxyls on there, but they're largely that drug is not that soluble in water. The specificity. The structural activity relationships of these molecules are based on substitution at positions 3 and 4 on the coumarin lactone ring. Because there is a weakly acidic hydroxy group in the 4 position, you can form salts. So not with dicumarol. So dicumarol was used as it was for a little while. It wasn't really as effective. Very quickly, they found that warfarin was actually a better choice. So warfarin can form hemiketals as well. So first off, we have I don't know if I delineated when the salt. Let's see where I would show that. Okay, I'll talk about the salts in this page. But warfarin itself, let's just look at here. So we have this ketone, right?
Mm-hmm.
That is dangling out there. It's attached to a phenyl ring. That can actually form a ketal. If you just really want to put it simply, we have a set of lone pairs on that hydroxyl that can come up and form a hemiketal with that ketone. So that's what I'm showing here, right? You get attack at that carbonyl. It can gain a proton, lose a proton. You could show this as a actual anion in solution. These wavy bonds indicate that it's kind of coming off and going on again. So we have that hemiketal that can form in solution. There are 2 diastereomers, right? Two hemiketals, they're diastereomers of one another. And it can exist in solution as either of those. So there have been some speculation that it forms an active hemiketal in vivo, and that the cyclic hemiketals can be part of the active conformation of the drug. The fact is it does form in solution, it's happening. What the extent of which I'm not going to really detail here, like which one would be more active. So we have the ketone that's being attached, forming the hemiketal. There's R and S warfarin. The clinically used preparation is racemic. They're not equipotent. The S warfarin is 2.5-fold more potent. And I just wanted to point out too that if we were to treat this with sodium hydroxide, I'm jamming up against it here, but we're forming a sodium salt. Boy, that's awful. Let's redo that. So that phenol hydroxyl is slightly acidic. If you treat that, or if you treat this molecule of warfarin or this one with some sodium hydroxide, you are going to form a sodium salt, and that's what I was suggesting on the earlier slide. This aids with water solubility. Otherwise, there's not a lot of functional groups that are ionized, or there are no functional groups that are ionized at physiologic pH. So overall, it's not that soluble. But if you add this sodium salt form, then that increases it. And maybe it is a sodium. I don't know if it is a sodium salt. Anybody know what warfarin is? What kind of salt it is? Warfarin sodium. It's warfarin sodium, right? Okay, so that makes sense. I just didn't know if it was potassium or something else. Okay, so it's rapidly absorbed from the GI tract. Its metabolism is by the CYP enzymes. This is actually, each person has a different profile, as you know from your pharmacogenomics. Dosing is entirely patient-specific. So warfarin requires a little bit of oversight and laboratory monitoring once they're getting started, from what I understand. And then long-term therapy is self-managed, I think.
You always have to go in for testing.
You always have to go
You
in?
always have to.
Okay.
Yeah.
Do people, well, tell me, does it like change over time then? I guess it would. If it's affecting all of those liver enzymes, and there are some genetic variability there, okay.
If
I
they
mean,
have, like,
patients that have been on it.
lifestyle changes and-
Yeah, okay, so yeah, of course, counting for lifestyle changes and any other physical changes that happen to the person, that's great, yeah. Not a pharmacist, remember, not a pharmacist. I like to hear this from you guys. Okay. I'll just go a few more minutes here and then just to talk about antiplatelets. Again, we're sort of rushing towards the end here, but we're going to talk about these in more detail in our NSAID section when we talk about NSAIDs and antihistamines like histamine blockade and all that stuff. It's commonly used for pain relief. It's commonly used for fever relief, as you know. It irreversibly inhibits COX enzymes and actually inhibits thromboxane A2 as well. So it's defined as a class 1 drug and it should be used in all patients. So I assume this is a first-line therapy. Gets used, it's proven to be relatively safe. As I mentioned, it irreversibly inactivates COX enzymes. You have covalent acetylation of a serine residue. So there is an acetyl transfer that occurs. Okay. So because platelets don't synthesize new COX, therefore the effects of elapsrin last the lifetime of the platelet itself. All right. So platelets take 7 to 10 days to regenerate themselves. So this drug is actually a long-term therapy because that new COX is not synthesized until a new platelet comes around. The ADP receptor antagonist, there's just a couple of examples. It started with ticlodipine. It's linked to a couple of really serious side effects. It irreversibly inhibits platelets at the ADP receptor. There are 3 agents here. Ticlodipine and ticlid isn't really used, but Plavix, I'm sure, is used quite a bit. And Plavix here is a very similar structure. They're called thionopyridines, and which is kind of an interesting pyridines. Because this isn't really a pyridine ring here. There's a thiene. You can see the thional or thiophene ring attached to a 6-member ring that has a nitrogen in it, but that 6-member ring is not a pyridine ring. They're called thionopyridines. This is used in combination with aspirin, treatment of ACS. Let me see. It has major case safety concerns in small patients. Again, so it has this. Oh, that's ticlodipine. Sorry, no, that's ticlodipine. So again, I'm reiterating what I said about ticlodipine. Clopidogrel lacks those safety issues. So Plavix is just a very slightly modified version of ticlodipine. See the structural similarities. It's literally only adding an ester to that. And finally, the GP2B3 inhibitors, they bind to that GP2B3 receptor. There are 3 agents that I wanted to point out here. I think the GP2B3 inhibitors, there's a mention of a PCI dose and a non-PCI dose. I think that's percutaneous coronary intervention. Somebody recall hearing that? I put that in the bottom with a question mark because these are what Dr. Zemrat's knows. And it just gives some dosing for each. You'll see that there's 3 classes of drugs here. Integralin is a peptide, Riopro is a monoclonal antibody, and Agristat, developed at where I used to work at Merck, is a non-peptide derivative, so that's actually a small molecule inhibitor. So we have the monoclonal antibody, the peptide, and here we have Agristat. And I wanted to point out, just real quick, sorry I'm taking it to the end here, if you look at the binding of epiphytide, there is a key lysine glycine aspartate. So I've put that in dark amino acids in dark bold lines there. That's highly specific to the GP2B3A receptor. So they've identified that as the actual binding site. There are elements to this structure that are key to that interaction. So the location of the carboxylate and the amine in the 5 bands is equal to the distance between the same functional groups and the arginine glycine aspartate or Arginine conforming to fibrinogen. So there actually is a connection to make to the actual natural peptide that's binding there. It has similar structural features as this. So I will be asking about that. Okay, that's all.